All right. Good morning, everyone. Thank you for being here for our cardiology grand rounds. My name is Suraj Mishra, one of the chief cardiology fellows. And today's lecture is extra special as it's our inaugural Dr. Walter Paulsen imaging grand rounds. Dr. Paulsen came to VCU in 1980 and spent the entirety of his career here. For 41 years, Dr. Paulsen provided exceptional clinical care and advanced imaging during interventional procedures and in the realm of high-risk obstetrics. As the lead expert imager, Dr. Paulsen played a significant role in creating and advancing the VCU Health Structural Heart Program. Throughout his career, Dr. Paulsen earned numerous excellence in teaching awards, highlighting his dedication to educating and training future healthcare providers and researchers. Dr. Paulsen's contributions to cardiovascular healthcare were exceptional, and his compassion and kindness were equally outstanding. Dr. Paulsen was beloved by all of us in the Pauley Heart Center, the health system as a whole, and renowned both nationally and internationally. In establishing this lectureship, we hope to continue to honor his legacy. Now I'm pleased to introduce our first speaker for the Walter Paulsen Imaging Grand Rounds, Dr. Naveed Naz. Dr. Naz has taken the role of structural imaging per Dr. Paulsen's recommendation. He has been working closely with structural interventional cardiology, electrophysiology, and cardiac anesthesia to attempt to maintain the high standards of quality established by Dr. Paulsen to support transcatheter edge-to-edge repair, left atrial appendage occlusion, ASC, VSC, and peri-device leak occlusion. We're grateful for Dr. Naz's expertise on this topic, look forward to learning from him, and at the end of the lecture, we'll leave time for some questions. Please submit them via the chat function on Zoom as they arise during the talk. We're pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit, text the code shown on the slide here to the number below. And I'll now turn it over to Dr. Naz. Thank you.
All right. Thank you so much, Serge. I'm going to get this screen back up. All right. Hi, good morning, everybody. Can everybody see my screen?
Yes.
All right, wonderful. Yeah, it is my great honor to do this talk in honor of Dr. Paulsen. I picked a topic that was obviously very near and dear to Dr. Paulsen's heart. It's something he established here in terms of structural imaging and supporting a vast array of structural intervention. We have obviously wonderful cardiologists doing lots of structural work, and in a lot of these cases, concomitant imaging is very helpful to the success of the procedure. Okay, so outline for my talk, we'll talk very briefly about what structural imaging is, and then I picked 3 pathologies that we'll go through that are very common in this institution, namely mitral valve, left atrial appendage assessment, and atrial septal abnormalities. I'm not going to focus on interprocedural imaging. That's a whole other topic beyond the scope of this talk, but we will talk about at least the first part of any sort of successful procedure, which is transseptal puncture of the interatrial septum. And then I'll make some final points about establishing an advanced imaging program here at VCU. So this sort of burgeoning field we call interventional transesophageal echocardiography is really based on the fact that there's been a very significant growth of transcatheter structural heart disease interventions. And so it's sort of created this subspecialty of interventional imagers who focus on pre-procedural planning and then obviously intra-procedural, peri-procedural guidance during these complex cases. And so, we focus on really doing T's to establish, number one, whether these cases are feasible, what the technical difficulties will be prior to case, so that we can provide a very good case planning and very good counseling to our patients, and then obviously intraprocedural guidance. So we'll start with the basic case. You see a 33-year-old female with palpitation dyspnea, and you'll see the stem a couple times during my talk. We get an echo. The echo shows this. So obviously there's something wrong here, and so this is sort of my foray into the mitral valve. And we always talk about saying that the mitral valve isn't just the mitral valve. The mitral valve is a very complex structure, and that involves multiple components. And so the overall sort of structure we call the mitral apparatus. And the mitral apparatus, of course, does include the mitral leaflets themselves, but also supporting annulus, the structures that support the annulus as well. We'll discuss a little bit later on. The chordae tendineae, the subtending papillary muscles, and even the subtending ventricular myocardium underneath the papillary muscles all compose the mitral apparatus. The three-dimensional structure of the mitral valve is typically seen as the letter D, when we get two-dimensional imaging, but it's not. It's much more of a saddle-shaped configuration, as we see here, and that is very important to its normal function. So, perturbation of this geometry can start to affect the mitral valve function, as we'll see here in a little bit. Generally, the anterior-posterior diameter is shorter than the intercommissural diameter that we see here, and it has a specific relationship with the aortic valve. And that relationship generally takes the shape of a saddle. So we sort of say that the normal mitral valve is saddle shaped, where the front is its relationship with the aortic valve, and the connecting tissue here is what we call the intervalvular fibrosa or aortomitral curtain. This structure here, which is typically the flat part of the letter D that we see in sort of two-dimensional imaging, typically comprises the anterior portion of the annulus, whereas the curved part of the letter D, the majority of the annulus, is going to be supporting the posterior leaflet. In a normal function of the mitral valve, there's a normal geometry, and that geometry comprises the relationship between the papillary muscle, the chordae tendineae, the atrial and ventricular muscle that supports the posterior annulus, the intervalvular fibrosa that supports the anterior annulus. Okay, and all of these comprise a normal geometry for the main function of the mitral valve, which is to support systemic pressure during ventricular systole. And then in diastole, the mitral valve has to be very compliant to open and prevent any obstruction of blood flow from the atria to the ventricle during diastolic filling. That is the job of the mitral valve. Certain parameters of normal geometry are the AP distance, the AP diameter that we talk about here. And from that, we get a sort of our annular plane, is sort of this virtual annular plane that we call. And the distance to our coaptation, we call our coaptation depth. The actual contact of the leaflets, we call our coaptation length. And again, these are all perturbed as we talk about pathology here. During systole, two things happens. You have closing forces on the valve, and then you have tethering forces of the valve. Closing forces obviously close the valve, tethering forces support the valve to maintain closure. And a lot of these tethering forces are transmitted through these chordae tendineae. And the chordae tendineae, we see sort of three types. We'll see primary, sometimes called marginal chordae tendineae, that support the leaflet tips. And then we see secondary chordae or basal chordae tendineae, also sometimes called strut chordae, that are going to support the belly of the leaflet during systole. And tertiary chordae are seen supporting, sort of connecting primary and secondary chordae as well. So when we talk about the mitral valve anatomically, obviously we all have to have a shared language, and we've really come to rely on the Carpentier system, which essentially takes the mitral valve. There are some normal scallops in the posterior leaflet, and it basically says, well, this is our lateral portion of the mitral valve, this is our medial portion of the mitral valve, and we name the leaflets based on these posterior indentations. So this P1 is going to be our most lateral portion, our P3 is going to be our most medial portion, P2 is in the middle. And then we name the corresponding anterior segments the same number, just for convention. Another proposed convention system is based essentially on the insertion of the papillary muscles. Your anterolateral papillary muscle has insertions in the anterior and posterior leaflet on the lateral half of the mitral valve, and the posterior medial papillary muscles has insertion on the anterior and posterior leaflet on the medial portion of the mitral valve. But typically we stick with this convention here. The most important thing about mitral regurgitation is mechanism, and then severity, in that order. So we really, every time we see MR, whether it's on surface echocardiography, but particularly on TE, is very, very important to define mechanism. As you'll see, our treatment is directly tied to our assessment of mechanism. And based on the Carpentier classification, we describe a mechanism based on leaflet motion, where you can have Carpentier type 1, which has normal leaflet motion. Type 2, you have excessive leaflet motion. And then type 3, you have restricted leaflet motion. Of note, we do have advanced Carpentier grades, type 4 in hypertrophic cardiomyopathy, and type 5 in hemodynamic alterations that can cause MR. But these are our main classifications that we use. And so in these classifications, you'll sometimes may hear the term primary and secondary mitral regurgitation. And essentially, primary mitral regurgitation refers to sort of a primary abnormality of the actual leaflet. And so whether you're talking about a perforation or a cleft, where the leaflet motion is normal, but of course you have perforation or a cleft, you have mitral regurgitation. Mitral valve prolapse, excessive motion of the leaflet, or thickening, scarring, or retraction, restriction of the leaflet that you might see in rheumatic mitral stenosis, where you have both mitral stenosis and mitral regurgitation. We call that Carpentier 3A. So primary, or sometimes you hear the term degenerative MR, and secondary MR. The leaflets themselves are not really pathologically. There's no significant pathology associated with them. However, it's all the geometry that we discussed above that's altered. Atrial functional MR, you have significant left atrial dilatation, which can displace your posterior commissure and cause tethering of the posterior leaflet, tethering the anterior leaflet. Non-ischemic cardiomyopathy, you have significant alteration in left ventricular geometry from a sort of a 3/4 of a football shape, what we call a prolate ellipse, to more of a basketball shape. Now you're significantly altering your papillary muscle geometry and efficiency. And ischemic cardiomyopathy, you can see here you have a basal infralateral scar that can really affect the posterior middle papillary muscle. And when that happens, you have significant retraction and fibrosis of your papillary muscle, so the posterior leaflet can't close appropriately. And that's, of course, going to affect more the medial portion of the valve, where the posterior middle papillary muscle inserts its chordae. Just another sort of word on this secondary mitral regurgitation. Again, it's alterations of closing and tethering. So if you have a person with significant cardiomyopathy, very weak ventricle, you have decreased closing force, decreased contractility. You could have left bundle and left ventricular dysynchrony. Of course, you could have decompensated heart failure, higher left atrial pressure, and your mitral annular dynamics and function may be decreased. So all these decrease your closing forces, and your tethering forces could be inappropriately increased. Global dilatation, you could have a more spherical ventricle, which is going to alter your papillary muscle geometry. Segmental dyskinesia like ischemic MR, and then papillary muscle alterations and annular alterations as well. So again, not a direct leaflet pathology, but sort of everything else when you're talking about secondary or functional MR. Histologically, we can see this is what it sort of would look like in the OR. This is a patient who has normal leaflet motion, but for very dilated annulus. They could be a HFpEF patient, they could be atrial fib patient. This is a patient with a Barlow valve. They have very redundant excessive tissue, and this is supposed to be sort of the question stem that I was showing, and the palpitations in this case could have been VT. Barlow valve can be arrhythmogenic and cause fibrosis, scarring the papillary muscle and the myocardium that can cause actually ventricular arrhythmias. This is a loss of commissures, so this is in very thick and retracted leaflet. So this is sort of the pathognomonic finding of rheumatic mitral stenosis. Again, we have bicommissural fusion, very thickened leaflets, fish mouth appearance, and this is a patient who has both mitral stenosis and mitral regurgitation, what we call Carpentier 3A. And then Carpentier 3B, again, this could be the ischemic MR, where you have very retracted posterior medial papillary muscle in your anterior and your medial anterior and your medial posterior, your P3 and A3, A3, P3, are very retracted during systole because the posterior medial is very scarred and retracted. So this is an example of Carpentier 3B. We sort of borrowed or stole from our heart failure colleagues, and we sort of talk about valves in a similar fashion. You should talk about staging of heart failure, but in all valvular pathology, A is at risk, B is progressive, C is where we have severe valvular pathology, whether it's aortic stenosis, mitral regurgitation, but they're asymptomatic, and then D is our symptomatic severe. For mitral regurgitation, we talk about the two most important mechanisms and we separate them. And we'll see why in a second, but it's because they have different treatment. But in chronic primary mitral regurgitation, you're going to have your severe mitral valve prolapse or flail, or rheumatic restriction, or leaflet damage, prior infective endocarditis, or potential radiation effects of the valve. This is our sort of criteria for severe MR with the 4, 5, 6, 7 rule. You have hemodynamic consequences of severe MR. You can have left atrial enlargement. Dr. Nishimura of the Mayo Clinic would say that if you have you cannot have chronic severe MR with a normal left atrial size. You are going to have left atrial dilatation. LV can be dilated, of course, pulmonary hypertension, and then usually manifest decreased exercise tolerance, exertional dyspnea. For primary mitral regurgitation, if they are a surgical candidate, our class 1 indication is going to be surgery. If they have a high or prohibitive surgical risk and their anatomy is favorable for a transcatheter approach, which is we're going to talk about here in a second, then there's a 2A indication for transcatheter edge-to-edge mitral valve repair. Sorry, this is a little bit small, but this is basically saying that there is no role for medical management in primary mitral or degenerative mitral regurgitation. If you do have ventricular dysfunction, you would manage that like you normally do. But if they're asymptomatic normal LV function, there is really no benefit for medical management in these patients. They need their valve repaired or replaced. In secondary mitral regurgitation, same thing. At risk all the way to severe symptomatic. So and then as really with secondary MR, really the goal is to optimize them as much as possible, as all of our wonderful heart failure attendings do. But after that happens, then with persistent symptoms, we generally will attribute to the severe MR and talk about therapy. But they basically may have heart failure symptoms that are going to persist after optimization of medical management, revascularization, CRT, etc. Decreased exercise tolerance, exertional dyspnea. So with secondary MR, with functional MR, there is no class 1 indication for treatment. But based on the co-op data, again, if you have an EF that's less than 50, persistent symptoms on optimal GDMT, CRT, etc., and you have a favorable anatomy, and you don't have significant left ventricular dilatation, or you don't have severe pulmonary hypertension, then again you would have a 2A indication for a for a transcatheter edge-to-edge mitral valve repair. If you're going for common surgical revascularization, then you'd have a 2A indication for some sort of surgical approach to the mitral valve. Of course, medical management is class 1 here, and the medical management is the standard medical guideline-directed medical therapy for heart failure with reduced ejection fraction. Okay, so we're going to tee this person now. So we're finally getting to the T portion of this talk. This is a transesophageal echo pro. We can do many things with it, but we're restricted by the esophagus. We're restricted by the esophageal relationship to the heart. But within the esophagus, we can push the probe in. We can pull it out, so we can advance. We can retract. Obviously, we can clock, counterclock. We can anti-flex and retroflex. And then with our small knob, we can actually right and leftward flex. And then in a standard examination at each level, upper esophageal, mid, deep esophageal, transgastric, deep transgastric, there are certain structures and hemodynamic assessments that we do that are part of the standard TEE. So this is the mitral valve as we see it on TEE. Of course, this is CMR, but these 4 are TEE anyways. This is our surgeon's view and our Carpentier classification. And I kind of tell fellows that this is looking at the patient as if their back is towards us, and we're looking through their scapula into the left atrium. And so their left arm would be over here, their spine would be over here. So this is the medial part. This is our lateral part. Left atrial appendage is out here. Okay. This is all part of the mitral annulus. The mitral aortic curtain is supporting our anterior annulus. Our posterior annulus is supported by epicardial adipose tissue, by atrial wall, by ventricular walls, as well as fibrous structures. Here in the transgastric, deep transgastric view, we have a very nice view of our papillary muscles of our chordae tendineae, including a primary and secondary, or marginal or strut chordae. We can see our papillary muscle and our trabeculations that usually demark the origin of the papillary muscle. When we image in TEE, we obviously like to optimize our view. So if we just drop the probe, we can get a decent view. But if we make some adjustments, if we rightward tilt our probe, we'll be more coaxial with the left ventricle, LA and LV in the mitral valve. And also, if we retroflex our probe, we're going to be more coaxial with the left ventricle. So you can see here we've optimized our picture, and we can see the apex of the mitral valve much better than pre-optimization. So we'll briefly go through the standard, exam, and I'm going to note features here that are very important with respect specifically to mitral valve pathology. So in our 4-chamber view, I'll show this picture here. Our 4-chamber view, we start with an inclination angle of 0. So we're sort of here at 0, and we're kind of looking at the ventricle in this respect. We can see our RV and our LV, this is sort of where the probe is looking. So if I retract the probe, I start to pull it up, this green line is going to go up. I'm going to see more lateral portions of the mitral valve. If I advance the probe towards the stomach, the green line is going to go down, and I'm going to see more medial portions of the mitral valve. So pull back, I see my A1P1. Push in, I see more A3P3. Okay, but usually we keep it right in the middle, and we're visualizing A2P2 in this view. And in this view, we're going to make our initial assessments of the valve. We can do something called X-plane, and X-plane essentially is looking at two views at once, 0 and 9, or whatever you're looking at, and 90 degrees plus whatever you're looking at. So in this case, it would be 0 and 90. So we've put on X-plane. We're seeing a 0 and 90 degree view of our LV, LA, and mitral valve here. We can do some advanced rendering technology to actually look at the three-dimensional saddle conformation of the mitral valve and how it changes during systole and diastole, but we don't typically do that. That's more of a research methodology. Here we see mitral stenosis, and something we'll talk about a little bit later is something called degenerative mitral stenosis, which is more based on mitral calcification encroaching the mitral valve, versus this, which is we call rheumatic mitral stenosis, where you have bicommercial fusion and leaflet retraction and thickening. We do hemodynamic assessment here in this view. So when we put continuous wave Doppler, we can see our mitral regurgitation jet, which is going, this way. Our MR is sort of going from the LV to the LA, so it's going to be above the baseline here. And this is our mitral inflow here. And with mitral inflow, we typically get our mean gradient, and we do denote the heart rate that we get the mean gradient at, and we can estimate valve area with our pressure half-time. We can also estimate regurgitant volumes through this method, and we'll talk about it here in a second. Our next view is probably the most important view, and now we're looking at the 45. So now we've increased our incidence angle from 0 to 45, and now we're cutting the valve through the commissures. So we call this the bicommissural view. We're cutting it here through this here, and so we kind of get a piece of our P3, our medial, which is this little thing here. Then we get sort of our A2 segment, which is this middle one here, and then we get catch P1 over here. Okay, so we're going medial to lateral in this view, and a lot of times we'll cut through the left atrial appendage here as well. This is very important in sort of determining where our mitral regurgitation is originating. And if we do an X-plane from here, well, 45 plus 90 is 135. We get what we call a mid-esophageal 3-chamber view. So here's medial to lateral, here's posterior anterior. So a lot of times when we get our bicom view, when we X-plane, we get a very nice layout. And a lot of times interprocedurally, when we're actually deploying the clip, we're actually maintaining this view. Of course, Dr. Hertz is most interested in our AP view, because that is our grasping view. So what we like to do, what's very important in assessing the MR, is when we see the MR in our bicom view, we really like to drop an X-plane line through it. And when we do, we'll see the MR in the AP view and in the grasping view. Then I turn the color off, and in the grasping view, I'll sort of we really want to assess that posterior leaflet there for length, for calcification, whether there's chordae. All those can influence the estimated procedural success for a grab and a mitral clip. Okay, so we really want to localize our MR by doing that. And the reason is, your MR can be anywhere along, obviously, the commissural line. And so what's most important is where is it, and then what is the posterior leaflet immediately adjacent to it look like. So if our MR is here, it doesn't really matter what the posterior leaflet over here looks like. We really want to know what the posterior leaflet here looks like, because that's where we're going to make our bite with our mitral clip, our grab. So again, BICOM is very important. I kept the slide in just to be aware that assessment of all the pulmonary veins is crucial during our initial TEs, or at least our right upper and left upper. And here you can see systolic pulmonary vein flow reversal. And we always get this interprocedurally. And as when we do our clip deployments, a lot of times we do see this reverts to normal antegrade flow, and that's sort of a marker of hemodynamic success of our clip. So pulmonary veins in our pre-procedural planning are very important to document. And then finally, we go to our actual grasping view, our 135 view. So now we're over here, and a couple of things we're studying here. So if we have we do look at this angle we call the alpha angle here. The smaller this is, the higher the chance for LVT obstruction if we do a mitral valve procedure, like a valve, a percutaneous valve or a surgical valve. If we have degenerative MR, we can measure something called the fluid gap. In 3D, you can measure the flow width, medical leaflet length, C-step distance. If we have functional MR, we can look at the coaptation depth here. We can look at the coaptation length. Or if there's no coaptation, we would measure what we call the coaptation gap. So we can sort of document that. Sometimes we use alternative 3D imaging, something called the glass view, and that sometimes helps us really localize the origin of the MR. We don't really care where the MR is going, but we do really care about where does it start from. And so that's really a very important thing to determine in our pre-procedural transesophageal echo. We can do PISA, and with sort of we can use three-dimensional assessment. We can align our planes and actually get a not just a vena contracta width, but we can get a vena contracta area. And as I'll show here in a second, that might be much more important in functional or functional or secondary MR, because the vena contractas in these patients are typically not spherical or circular, and so they can be very oddly shaped. Again, just reiterating that we want to, a lot of times, our two working views are our bicommissural view, and then at 90 degrees, our grasping view. And we really want to study our pathology in these two views to really, so we can have good planning. In this case, we see a posterior, severe posterior prolapse. We see that same posterior prolapse here. This is sort of upside down surgeon's view. Typically, when we look at our 3D, we put our aortic valve on top by convention. So now our posterior leaflet's on the bottom. We can see our P2, severe P2 prolapse here. We then advance the probe into the stomach to get our transgastric views. And that's where we can see the short axis of the LV well. So we can look at LV function. We can look at the mitral valve again. I will tell you, sometimes we had patients with very poor mid-esophageal views, and after we deploy the clip, sometimes our transgastric view is the only one that really shows that we have good appropriate grasp of the leaflet. So we really can confirm tissue bridge in this view. So I usually get it in my pre-procedural TE, just so I know that it's there if I need to use it. And so we can see, obviously left ventricular function. In this view, we can really study our papillary muscle and chordae tendineae as well, very well. I actually do this view a lot of times for endo to make sure there's no endo hiding out in the subvalvular apparatus. Sometimes you have very eccentric MR jets that you see actually most appropriately in the transgastric view, and you always want to hemodynamically assess a jet as coaxial as you can. So if it's in this view, then that's where we would sort of do our hemodynamic assessment. So quantitative methods for MR, I'm not going to spend too long on. Everybody gets confused about this thing called PISA. The way that I explain it is we all are very familiar with the continuity equation. We have the LVOT, we have our aortic stenosis right here. So we get our LVOT area, we say is A1. We assume every point on this circle here has the velocity V1. If you do dimensional analysis, area is centimeters squared, velocity is centimeters per second. When you multiply the two, you get centimeters cubed per second, which is mLs per second. It's a flow. And with a closed fluid system, flow is conserved at any point in the system. So Q here is going to be Q here. So we can say A1V1 is going to equal A2V2. We can measure V2, and then we can calculate aortic valve area. Well, PISA is the same thing, just on its side. So now during MR, we're trying to calculate the estimate the regurgitant orifice area. And so it's the same calculation. You have some kind of area, some kind of velocity, and you're going to get another velocity, and then you'll be able to calculate the other area. So it's the exact same thing. The difference is our area now is the hemisphere, surface area of the hemisphere. It's not a circle anymore, but it's still an area. Our velocity now is our Alicine velocity. So we know that at this velocity, every point on this hemisphere is this velocity. So we have an area, we have velocity, and again, we have A1, B1. And then, so we have a flow. And we can get V2, which is the peak MR velocity, and then we can calculate our estimated regurgitant orifice area. Okay, so PISA is essentially another form of the continuity equation, and that's all it is. We can also calculate regurgitant volume. We can calculate regurgitant fraction, which is the relation of our regurgitant volume to our stroke volume. And just of note, again, when we look at vena contracta area, a lot of times we're finding that patients who have functional or secondary MR, they don't have a circular sort of vena contracta as we typically see in degenerative MR. So our PISA calculations may actually not be as valid because it may not be assuming this sort of hemisphere configuration that it would in a sort of circular MR. So the guidelines are more and more recommending actually measure this vena contracta area in our determination MR. Remember, severe MR, I call it the 4, 5, 6, 7 rule. Estimated regurgitant orifice area greater than 0.4, severe. Studies have shown the vena contracta area very similar, about 0.41 is consistent with severe MR. Regurgitant fraction greater than 50%. So half of your left ventricular volume is going backwards, half is going forwards. That's severe MR. Regurgitant volume greater than 60 cc's. Vena contracta width greater than 7.7 centimeters. And we consider this a relatively the vena contracta to be independent of bloating conditions. So we like to look at that. So again, to summarize, for our assessment of MR, again, we want to measure our coaptation depth and our gap. We really want to localize our MR appropriately, get our vena contracta area. We want to look at our diameters. I did mention before, but we really do want to get a good assessment of valve area by three-dimensional polarimetry, whether in a 3D or more ideally in a biplane, well-aligned 2D view. So we know our risk of mitral stenosis when we put a clip on. Tenting height, coaptation depth. And again, it's very important to know exactly what that posterior leaflet looks like at the level of the mitral valve pathology. Again, using our biplane to localize it, using our bicommercial view, and then putting an X-plane through the MR, looking at our grasping view, because things like chordal calcium, a primary chord or marginal chord A, calcium on the actual valve, a very short posterior leaflet, all can significantly decrease procedural success. So these are things that are very important to denote in our pre-procedural exam. And by procedural success, I mean that the mitral clip may have a tougher time grabbing onto those things, and you may have a higher risk of it slipping off. Okay, so again, another 33-year-old female with palpitations and dyspnea. You get an echo, and now you see something like this. So this is characteristic of rheumatic mitral stenosis, fish mouth appearance and doming, diastolic doming, and bicommercial fusion and thickening of the mitral valve. Obviously, we see this in patients who may not have been adequately treated for their streptococcal infections, and it can incite an inflammatory response to the valve. So we'll talk a little bit about mitral stenosis real briefly. Predominant mechanism by far is going to be rheumatic, but we're seeing more and more of this in our elderly patients, where you can have significant mitral artery calcification that can start to encroach and cause mitral stenosis. So stages, again, at risk all the way to symptomatic severe, and we define severe as mitral valve area less than 1.5 centimeters squared. And I point this out because, well, it used to be 1.0 centimeters squared, and I think they realized that a lot of the hemodynamic consequences sort of occur below 1.5 centimeters squared. So this is the new severe. And then hemodynamic consequences are going to be left atrial dilatation and pulmonary hypertension. Symptoms are going to be decreased exercise tolerance, exertional dyspnea. So again, for rheumatic mitral stenosis, obviously there's no rule for clip in mitral stenosis here, but you can talk about percutaneous balloon valvotomy with the Amenable balloon, mitral valve surgery as well. So especially if these are younger patients with relatively unaffected valves, the balloon might be reasonable for those patients. On TEE, we can see again the same sort of appearance that we get with surface echocardiography. Just a quick note about this other type of MR. It is very challenging, when you have significant mitral artery calcification and you have, mitral stenosis on MR. But this is a very tricky beast, because this MAC, surgeons really don't like debriding this. It can be very tricky in the OR, and it may be very difficult to seat a valve in here without really appropriate debridement. Because this may not be a regular contour surface. So, this is certainly a challenging problem, and we do see a number of cases here at VCU with the mitral stenosis, we call it degenerative mitral stenosis. So, all right. So moving away from the mitral valve, we'll talk about another thing we do a lot of here. This is a 75-year-old male with AFib who had a significant GI bleed, and it's going to be someone that we consider for left atrial appendage exclusion. So for the 2019 guidelines, it's reasonable to consider patients with AFib with increased risk of stroke who have contraindication to long-term anticoagulation. The left atrial appendage on TEE is very well seen. It is a structure we really can't see well on surface echocardiography, but with the TEE, as you can see here, we can really see the appendage well. We have the ostium, the body, and the tip or apex of the appendage. And it's always important to identify the surrounding structures: left pulmonary vein, limbus, the LA ridge, the transverse sinus, which may have fluid in it, circumflex artery, and then the great cardiac vein. So these are all surrounding structures for the mitral valve. For the left atrial appendage. The left atrial appendage can have multiple shapes. These are agreed upon names. We can have sort of a windsock appearance. We can have a chicken wing. Predominantly we have an anterior chicken wing here. You can have a broccoli configuration or cactus. The more regular the appendage, probably the lower the stroke risk. The more irregular the appendage, probably the higher associated stroke risk. Very important when you really look at the left atrial appendage is to identify, thrombus, as opposed to sludge, as opposed to smoke, and this is sort of a normal left atrial appendage. So obviously when we do our T's prior to cardioversion, this is our primary focus, is to identify any sort of residual thrombus. But for a Watchman device, we of course have to exclude thrombus, but we also have to give the size and shape to our electrophysiology colleagues for them to determine the feasibility of the procedure. And so, the standard views that we do are these four insonation angles: 0, 45, 90, 135. And that allows us to get a very good estimate of the size of the left atrial appendage orifice. And the left atrial appendage orifice typically is not circular, it's more elliptical. So, you may have your 0 and 135 be larger than your 90 and 45, for example. You can look at it on 2D as well, and you can see that it's typically elliptical in appearance. But these measurements are very important obviously in determining the feasibility. Predominantly, I think greater than 90% of human beings will have left atrial appendage that will conform with a device size, but some patients have an appendage that is too small or too big, to which a standard Watchman flex would sort of fit into. So again, sorry, just to reiterate these angles for the Watchman. This is for other atrial septal occlusion devices that we typically don't do here in VCU. So I tend to do these on a lot of my ITs and older patients because I figure I'm in there, I'll get the data. Just in case this patient does get a Watchman, at least we'll have some initial data. All right. Our sort of last structural consideration, again, we're going to have 33-year-old female palpitation, shortness of breath, and now you do an echo, and in the your subcostal view, this is what you see. So we'll talk a little bit about atrial septal defects and patent foramen valley. So in patients with a secundum ASD, impaired functional capacity, RA/RV enlargement, large enough shunt to cause hemodynamic sequelae, we say QPQS greater than 1.5 to 1, who don't have cyanosis, and they don't have significant pulmonary hypertension or elevated pulmonary vascular resistance. They are amenable to PFO closure, whether it's percutaneous or surgical. Other types of ASCs, which I'll show you here in a second, typically aren't amenable to percutaneous closure just based on their location and surrounding structures. But they would be sort of considered surgical closure for the same criteria. In terms of PFO, a stroke guideline from 2021, AHA and the neurology stroke consensus statement, really says that patients who are 18 to 60 who have a non-leukemia ischemic stroke of undetermined cause, despite a thorough evaluation, and PFO with a high anatomic risk features, reasonable to close with transcatheter device and long-term antiplatelet therapy over antiplatelet therapy alone. So there's where we kind of think about PFO closure. So talking about the atrial septum, we will start by sort of talking about the way that it's dispositioned. And, we have our superior vena cava, inferior vena cava, and this defines our superior inferior aspect of the atrial septum. And then on this end, you have your sort of aortic valve and then your posterior atrial wall. So that's going to define your anterior posterior aspect of your atrial septum. We'll get back to that in a second. These are the different types of VSDs, the most common being your secundum VSD, but you can also have sinus venosus. I'm saying VSD, pardon me, ASD. You can also have sinus venosus ASDs. You can have a primum ASD, which is really a partial AV canal defect, and very rarely can have a coronary sinus ASD as well. So, in TEE, we lay out the atrial septum in sort of our two standard views, and we take advantage of these structures to determine what's superior, inferior, and what's anterior, posterior. So, but when we do identify an ASD, obviously we want to know its location, the type of ASD we're talking about, and very importantly, the size, if it's a secundum ASD. And what's important to our structural interventional cardiologist is the rims of the ASD, particularly the inferior rim. How much can they grab onto? A short anterior rim, used to be concerned, but they can work around that, but the inferior rim can be challenging. First of all, to visualize, but also if it's short, percutaneous intervention may be difficult. So when we're looking at the atrial septum, again, we want to know the ASD size, location. Look at a PFO, we want to look at its tunnel length, and sort of where it spans, distance from PFO to the vena cava, any kind of shunting. In both cases, particularly if you have sinus venosus ASD, you want to exclude anomalous pulmonary venous connections. And with ASDs, in rarer cases, probably less than 5% of the time, they can have multiple fenestrated ASDs, so they have more of a Swiss cheese in atrial septum, and that can also be more challenging to fix percutaneously. You always want to set the site of transeptal puncture. These are our standard views for ASD. This is looking at an atrial septum here in our metaesophageal 4. At 45 degrees angle, a short axis view, this lays out the aortic valve in the posterior atrial wall. When you have the aortic valve in the posterior atrial wall, that lays out your anterior posterior view of the septum. When you have your superior vena cava, inferior vena cava, that's going to lay out your superior inferior part of the septum. Here you obviously have a very large ASD with very, very short rims. Here, a smaller secundum ASD with very, very adequate rims. So obviously these are things that you want to identify in the TE for our structural cardiologists to know for planning. A lot of ASDs, the structural interventional cardiologists are very good with intracardiac echo, and they don't necessarily need TEE during the procedure. But in some cases with the deficient rims, we do help them during the case, just to get a second set of eyes to make sure the device is seated well. Again, we want to measure our rims and our superior and inferior aspect and our anterior and posterior aspect, and provide good imaging for our cardiologists and our structural interventional cardiologists, and also to assess our hemodynamic effects of our ASD. All right. Good. So I'm going to the only thing that I pointed out here, this is a fenestrated ASD, which sort of multiple jets. And again, this is something you don't want to miss because we find one sort of jet and they close it, and then there's a couple of jets here that we missed. We didn't really do our jobs as imagers and really identifying the full extent of the ASDs in a fenestrated ASD situation. So so the next topic I'm going to cover briefly is interprocedural guidance. Again, I'm not talking about the particulars of every case, but what's common to every case is transseptal access. So I do want to talk about it here. It is a very, very important step in any sort of procedure. And the goal is to achieve left atrial access in a manner allowing safe passage of large bore catheters at a heightened position that enables necessary manipulation and positioning for the intended procedure. We want to obviously avoid trauma to adjacent structures, and we want to make sure that we can safely exit the left atrium when the case is finished. First transseptal puncture was by Morrow and Brunwald back in 1959, where they just crossed over to measure left atrial hemodynamics. Since that time, there's been an evolution with percutaneous mitral, valvuloplasty, and then the biggest growth of transseptal puncture was really with pulmonary vein isolation. Then we have left atrial appendage occlusion, percutaneous LVADs, paravalvular repair, and then transcatheter mitral valve repair or implantation. So, multiple procedures that we do, but a lot of what we do here obviously is going to be our mitral clip or tier, and our left atrial appendage occlusion with the Watchman device. Of course, pulmonary vein isolation. Again, the atrial septum, we have the anterior posterior aspect, superior inferior aspect of it. And so what you see with different procedures here, we sort of want to cross at different points of the fossa ovalis, and the reason being is going to allow us for optimal coaxial access to our target, whether that's a mitral valve or whether that's the left atrial appendage, for example, or pulmonary vein. That can significantly reduce procedural times, increase procedural success. So planning on actually where you're going to cross is very important. Again, anterior, posterior, superior, inferior disposition. So you can see here that in your interatrial septum, an axial view, you can move anteriorly, posteriorly. The screen arrow is going to be more of an anterior cross, whereas the right arrow is going to be more of a posterior cross. And again, we can show that in TE by displaying our aortic valve and posterior wall, where as you move towards the aortic valve, it's going to be more anterior, and then it's going to be more posterior in this direction. Concomitantly, we can simultaneously show them our superior inferior axis by what we call our bicable view. And so you can see the same needle is tented a little bit superiorly and a little bit posteriorly. And so, I can show them that real time with an X-plane, and they can sort of decide, along with some additional fluoroscopic data, that this is a good place. This is a good place to cross. Okay. So a lot of times when we do the transcatheter edge-to-edge repair, we also go to our zero angle and we get a height. So once we see the needle pushing, again, I'll show this in the superior inferior view and the anterior posterior view. But then also we'll look at a 0 degree to sort of say, okay, when we do cross, we're going to have this much distance to work before we have to engage the mitral valve. And obviously, if it's too short, then our move is to actually go a little bit more posterior to give us a little bit more height. Some complex interatrial septum considerations include, adipose tissue or lipomatous interatrial septum hypertrophy, fibrosis, scarring from prior manipulations. Those can all make transseptal access a little bit more challenging. There is some software which actually combine your T view and your fluoroscopic view. They call this kind of hybrid imaging. And then it's a sort of three-dimensional assessment of your tenting point. Majority of cases here, though, are done using a combination of fluoroscopy and intracardiac echo, which obviously can give you the same sort of information necessary in terms of your anterior posterior disposition, and in this case, your superior inferior disposition of your cross before you actually cross. All right. So, last thing I did want to talk about here is this, this field of interventional echocardiography and potentially supporting a training program here. Dr. Hundley has tasked us with establishing one, which I think is very, very sort of insightful and something I do believe we can support. Very recently, sort of hot off the presses, the ASC has released a document talking about training for interventional cardiology, if you will. So where you kind of move up in your COCATS training to level 3, you can typically get level 1 and 2 in a general cardiology fellowship. Level 3 in a dedicated fellowship where you do a lot of elective echo. But typically it's hard to get this level 3 with interventional echocardiography because you do have to do a lot of structural procedures. So typically this would require a dedicated period of time after your general cardiology fellowship. But I do believe this facility is well suited to support this kind of training. We have excellent faculty. We have a great heart team, interventional cardiology, cardiothoracic surgery. We have great facility. We have great caseload, great GME support. These are just sort of proposed numbers of what we would want our trainees to do. Structural valve interventions, transcatheter guidance, percutaneous closures, perivalvular leaks, alcohol septal ablations, Watchman devices, and then even intraoperative TEs and ICE, which our cardiac anesthesiologist and electrophysiologist have graciously agreed that they could support. So, I think going forward, this institution would be, very nice to support trainees if they're interested in advanced imaging. And our advanced imaging program here would be a combination of MRI, cardiac CT, hopefully, and also advanced structural echocardiography. So with that, I'm going to close it. Hopefully not over time, and really want to thank all of my imaging colleagues, Dr. Gertz for supporting me through my trying to get up to speed to what Dr. Paulsen left. EP and cardiac anesthesiology has also been very supportive. And of course, I can't say enough about Walter, how much we miss him. Obviously, he was such a superb and generous mentor, but he also was a very good friend to me and to a lot of people. So he's dearly missed. So I'll conclude and be happy to answer any questions.
Thank you, Dr. Naz. That was a wonderful kind of overview on structural imaging, and a very exciting field for sure. I know we have a few questions in the chat, and people can certainly drop them in. My question was, I guess as I'm learning TEs, sometimes getting a good look at the tricuspid valve is pretty challenging. And so if, you encounter limited views, whether in the pre-procedural, interprocedural setting, are you using ICE during the tiers for this, or?
Yeah, so that's a great question. So we're involved in a trial for tricuspid clips. We haven't really done too many of those cases. So but in general, the expectation is that the learning curve for tricuspid is going to be significantly higher than for mitral valve, because the anatomy of the tricuspid valve is much more variable. The mechanisms of tricuspid regurgitation, can be a little bit more challenging and difficult. So, and like you said, imaging, it's more anterior structure, can be challenging. So, I think it all sort of depends. I do feel that, ICE may be complementary. A lot of times when we do Watchmans, we have T and ICE, transesophageal echo and intracardiac echo. So, because sometimes you get the optimal view with one modality, sometimes you get the optimal view with the other. So I imagine that ICE would play a part when we start doing these tricuspid clips. But again, the expectation of the preliminary data is really showing that the tricuspid valve is going to be more challenging. And a lot of times I go to the transgastric view of the tricuspid valve as well. That seems to really lay it out nicely. Sometimes if you don't get good mid-esophageal or deep esophageal views. But yeah, I do think any imaging modality that's going to help tricuspid valves we'll use.
We have a question from Dr. Naveed Paul. Great talk, Dr. Naz. Mechanistically, is it just the pressure gradient difference in chambers that opens the valve leaflets, or is there something else too about the subvalvular apparatus that enhances the opening even before these pressure differentials happen? That's a great question. Dr. Gertz is actually very, very, I think, the expert on sort of opening and closing forces of the mitral valve. I may defer to him, but in terms of mitral valve opening, you're going to have obviously a reversal of all the initial closure and tethering forces. So obviously your left ventricular pressure is going to drop. But any sort of distortion to your mitral annulus is going to sort of revert prior to mitral valve opening. And we know when we sort of see alterations in MR, we know that if MR MS occur at different times in the cardiac cycle, it's not as efficient. So I think there are a lot of conformational changes that occur that make mitral valve opening more efficient, and they're probably the opposite that cause the mitral valve to close. So it's the reversing of the closing and tethering forces. Great. Any other questions from the audience? If not, thank you again, Dr. Naz. Thanks so much. Again, the CME code is listed on the slide here. But thank you to everyone for joining us today. All right. Thank you.